Okay, so you want to open a private hospital. You're picturing something specific. A glass lobby, doctors in white coats walking with purpose, a building with your name or your investor's name cut into the stone above the entrance. Prestige, permanence, the kind of business that never runs out of customers because people never stop getting sick. Hold that picture for a second and put a different one next to it. A hand-painted plywood sign staked into a lawn in Ayer, Massachusetts. For words, black paint on white board. Save our hospital. By the time most people outside that town ever saw a photo of that sign, the hospital behind it had already closed. Neshoba Valley Medical Center. Gone. $9 billion. That's how much debt the hospital chain that owned it was carrying when the whole system collapsed in 2024, the largest hospital bankruptcy in decades, and one of the largest corporate bankruptcies of any kind that year. Nobody who signed the paperwork to open those hospitals thought they were building toward a lawn sign. Nobody standing in that Ayer, Massachusetts lawn painting the letters was thinking about real estate investment trusts or dividend recapitalizations or a private jet purchase somewhere else with money that, technically, started as their hospital's own building. So somewhere between the glass lobby in your head and the plywood sign in Massachusetts, there's a business model. That's what the next 30 minutes are about. Not a company that failed, but the machine that private hospitals actually run on, who really owns each piece of it, and why the people who build that machine are rarely the ones left holding it when it finally breaks. Here's the first thing that surprises most people. Hospitals are not, as a rule, a private equity business. Most of the roughly 5,100 community hospitals in the United States are still nonprofit or government-owned, run by boards, not funds, with no shareholders expecting a payout at the end of the fiscal year. Private equity firms own somewhere between 460 and 488 of them, depending on which year's count you use. That's a small slice on paper, about 8 to 8.5% of all private hospitals in the country. Overall, private equity has poured an estimated $1 trillion into healthcare acquisitions of every kind since the early 2000s, and in 2024 alone it was involved in roughly 1,069 separate healthcare deals in the United States. Hospitals, physician groups, urgent care chains, home health agencies, addiction treatment centers, all of it. But slice the number differently, and it changes shape. Among for-profit hospitals specifically, the ones actually built to generate a return for owners, private equity now controls more than 22%. One in nearly every 4 for-profit hospital beds in America sits inside a private equity-owned system. And hospitals were never the entry point. Physician practices were. In 2012, private equity firms controlled 816 physician practices nationwide, a rounding error. By 2021, that number was 5,779. Not a rounding error anymore. Almost 7% of physicians today report their practice is owned by a private equity firm. The firms learned the economics of medicine on the smaller, faster deals first: dermatology groups, anesthesia groups, emergency room staffing companies, and hospitals came later, once the model was proven. Here's the part that almost nobody outside the industry understands going in. Owning a hospital and owning the building a hospital operates inside of are two completely separate businesses, and they don't have to belong to the same person. A hospital operator can lease its own building from a landlord who has never treated a patient in their life. That landlord is often something called a real estate investment trust, a REIT, a public company that exists purely to own property and collect rent from whoever's running the business inside it. And as we're about to see, that split between the operator and the landlord is not a technical footnote. It is, for the private hospital business model, the whole story. It's also worth being precise about what private equity hospital actually means, because the phrase gets used loosely. It doesn't mean a single billionaire owns a building. It means an investment fund, money pooled from pension funds, university endowments, insurance companies, and wealthy individuals, bought a controlling stake in a hospital system with a specific, time-limited plan, improve the numbers, then sell the whole system again within roughly 5 to 7 years, either to another fund, to a public company, or through an IPO. A hospital, under that structure, stops being a permanent institution and becomes a position in a portfolio with an exit date already penciled in before the ink on the acquisition papers is dry. Steward Health Care is the case that made national headlines in 2024. It was not, as we'll see later in this episode, the only one. Prospect Medical Holdings, another private equity-backed hospital chain, filed its own bankruptcy roughly a year later, in 2025. Different owners, different states, a strikingly similar shape. So let's say you're serious. You have the capital or access to it. What does it actually cost to stand up a hospital from nothing? Not lease an existing one, not buy a struggling nonprofit at a discount, but actually build one. Start with the building. $1 million. That's the rough construction cost benchmark per bed that hospital planning consultants use before a single brick gets laid. Anywhere from $500,000 to $1.5 million, depending on the type of unit, with intensive care and surgical space running well above that average and standard patient rooms running below it. A modest 120-bed community hospital at roughly 2,500 square feet of building per bed lands you a project cost north of $110 million before you've hired a single nurse. A large tertiary hospital, 500 beds and up, can run past $900 million. That's before you're allowed to open the doors, because in most of the country, you don't get to decide there's demand for a hospital. The government does. 35 states plus the District of Columbia still run what's called a Certificate of Need program, or CON. Before you can build a new hospital, add beds, or in some states even buy a piece of major equipment, you have to petition a state board to formally certify that your community needs it, and the hospitals already operating in that market are allowed to show up and argue that it doesn't. Researchers comparing con states to non-con states have found con states end up with roughly 30% fewer hospitals per 100,000 residents and close to 99 fewer hospital beds per 100,000 people. The law that was supposed to prevent wasteful overbuilding also, structurally, protects whoever got there first. To be clear about what arguing that it doesn't looks like in practice, con hearings are adversarial by design. An existing hospital system can hire lawyers, submit its own utilization data, and formally oppose a competitor's application on the grounds that the market is already served. The same hospital that stands to lose patient volume if the new facility gets approved is invited to help decide whether it should be. 11 states have repealed con laws entirely, California, Texas, and Pennsylvania among them. And researchers comparing those states to the 35 that kept the requirement found the con states also end up with meaningfully fewer rural hospitals and fewer standalone surgical centers per capita, not more, undercutting the original argument that the law protects rural access. Say you clear that hurdle. The costs don't stop, they layer. Land and construction, the first layer, we've already covered. Regulatory accreditation and life safety compliance is the second. Fire suppression systems, seismic bracing in some states, infection control ventilation, backup power systems rated to run an entire operating floor through a grid failure, all mandatory before a state licensing board, or an accrediting body like the Joint Commission, will let a single patient through the door. None of that is optional, and none of it generates revenue on its own. It's the cost of being allowed to exist. Specialized clinical equipment is the third layer, an MRI suite, a cardiac catheterization lab, a Level 2 neonatal intensive care unit, each one a multi-million-dollar line item with its own separate certification process, its own maintenance contract, its own staff trained specifically to run it. And staffing is the layer that never stops compounding, because unlike a building or a machine, staff has to be paid every single pay period for as long as the hospital exists, indefinitely, whether the beds are full or half empty that month. At the nonprofit hospitals with the most complete public data, personnel costs alone consume roughly 54.5% of total operating revenue. Before rent, before supplies, before debt service, just wages. And that share has been climbing, not falling, as hospitals compete for a shrinking supply of nurses willing to work the shift. And after all of that spending, look at what you're left chasing. Hospital operating margins cluster in a tight, punishing band. At the top, roughly 15% of hospitals operate with margins above 15%. In the middle bottom, about 22% are running positive but thin, under 5%. And at the very bottom of the positive range, roughly 1 in 10 hospitals is clearing less than 2.5%, barely above break-even, one bad flu season or one delayed insurance reimbursement away from the red. For the median nonprofit hospital specifically, the operating margin in 2024 was 1.2%. Finance textbooks generally put the minimum sustainable margin for a hospital, the number needed to keep replacing aging equipment and buildings over time, at around 3%. Most of the industry is running below the number it needs just to stand still. That's the picture before anyone extracts a dollar of profit for themselves. Now here's where it gets interesting. If margins are this thin and this fragile, why would anyone with serious capital want in? It's a fair question, and it's the one that unlocks the rest of this episode. Because the money was never really supposed to come from running the hospital well, quarter after quarter, for 30 years. It comes from a structure sitting one layer above the hospital itself, a structure that generates its return almost entirely independent of how many patients walk through the door. Remember the landlord we mentioned, the real estate investment trust that owns hospital buildings without operating a single one of them. Here's how the mechanism actually works. A private equity firm buys a hospital system. At some point, sometimes years later, sometimes almost immediately, the system sells its own hospital buildings to a REIT for a large lump sum of cash, and then signs a long-term lease to keep operating inside those same buildings, now as a tenant instead of an owner. That transaction is called a sale-leaseback. The hospital system walks away with a mountain of cash today. In exchange, it takes on a fixed rent obligation for decades, whether the hospital down the hall is profitable that year or not. On one side of that transaction sits the operator, nurses to staff, insurers to negotiate with, a median margin somewhere between 1% and 2%, absorbing every bad month personally. On the other side sits the landlord, a fixed lease check, collected on schedule, indifferent to whether the ER down the street was full or empty that quarter. The rent doesn't care about patient volume. It's owed either way, and the cash from that sale-leaseback doesn't have to stay inside the hospital system at all. A large share of it can move straight out to the private equity firm and its executives as a dividend. This is sometimes called a dividend recapitalization. Raise cash against an asset you own, then pay a chunk of that cash to yourselves as owners, and leave the operating company holding the resulting debt and lease obligations. The hospital keeps its name on the door. The bill for the transaction stays behind, on the balance sheet, for decades. There's also a documented cost on the clinical side, not just the financial one. Peer-reviewed research comparing private equity-acquired hospitals to otherwise similar facilities has found the acquired hospitals saw a 27% increase in patient falls, a 38% increase in central line bloodstream infections, and, in a separate 2025 study, a 2.7 percentage point increase in 30-day mortality following surgery. None of those numbers show up on the deal memo. They show up months or years later, quietly, in hospital quality reports nobody outside the industry reads. Fewer nurses per patient, less time spent on preventive checks, more corners quietly cut on the maintenance and staffing that don't show up in a quarterly earnings call, but absolutely show up at a patient's bedside. This isn't a one-company story, either. Prospect Medical Holdings, the hospital chain that filed for bankruptcy in 2025, ran on a nearly identical playbook to Steward's: private equity ownership, a sale-leaseback of its hospital real estate, a large dividend distributed to its owners years before the bankruptcy, and hospitals in Connecticut, Pennsylvania, and California left scrambling for new operators once the debt came due. Two different funds, two different sets of executives, two different sets of states. The same underlying structure, run twice, with the same outcome both times. That's the difference between a scandal and a business model. A scandal happens once. So the operator absorbs the staffing costs, the insurer negotiations, the thin margin, and, increasingly, the documented decline in patient outcomes. The landlord and the equity owners absorb the upside. That asymmetry is not an accident of any one company's mismanagement. It's the design. Here's what that design looks like when it finally runs out of road. In 2010, a private equity firm called Cerberus Capital Management paid $830 million for 6 struggling Catholic nonprofit hospitals in Massachusetts. Caritas Christi Health Care. They renamed the system Steward Health Care and installed the hospital's own CEO, Dr. Ralph De La Torre, to run it. On paper, it looked like a rescue. A nonprofit chain that had spent years failing to find a buyer finally had won. 6 years later, In 2016, Steward signed a $1.25 billion deal with a real estate investment trust called Medical Properties Trust, MPT. $600 million of it came from selling off the real estate under 5 of Steward's original hospitals and leasing it straight back. Another $600 million came from refinancing mortgages on 4 more Steward-owned hospitals. Steward used that money to go shopping. In 2017, it bought Yasha's Health Care, expanding the system to 36 hospitals across 10 states, with international operations in Malta and Colombia added not long after. Watch the numbers escalate here, because each one sets up the next. $830 million to acquire the original 6 hospitals in 2010. $1.25 billion pulled out through the real estate deal in 2016. And in 2020, when Cerberus finally exited its ownership stake through a buyout led by De La Torre and MPT, investigators and lawmakers say the firm walked away having extracted somewhere around $800 million in profit. Cerberus disputes the precise figure, but has confirmed a substantial return. Later reporting from investigative journalists put the combined total pulled out by Cerberus and Steward's own leadership across the life of the deal at roughly $1.3 billion. Around the time of that exit, Steward paid a $111 million dividend to its owners. Dr. De La Torre subsequently bought a $40 million yacht, 2 private jets, and a private suite at an NBA arena in Dallas. The hospitals kept his name off the letterhead but carried his decisions on the balance sheet. By 2024, Steward was the country's largest private hospital operator by hospital count, and it was also nearly $9 billion in debt, with $6.6 billion of that specifically tied to the lease payments owed to MPT. May 6, 2024. Steward Health Care filed for Chapter 11 bankruptcy. 31 hospitals, 10 states, almost 30,000 employees whose jobs were suddenly a question mark. Hospitals began closing that summer, including Neshoba Valley Medical Center in Ayer, Massachusetts, shut for good on August 31, 2024. That's the lawn we opened this episode with. By the time the sign went up, the decision had already been made somewhere else, years earlier, in a financing document nobody in that town had ever read. The damage wasn't confined to Massachusetts. Wadley Regional Medical Center, serving communities straddling the Arkansas-Texas border in Hope and Texarkana, faced immediate closure risk the moment Steward filed. This was a chain that, on paper, spanned 10 states, which meant the bankruptcy of a single financing structure put hospital access at risk simultaneously in New England, in the South, and everywhere in between. A patient in rural Arkansas and a patient outside Boston had, without knowing it, been depending on the same real estate deal to keep their local emergency room staffed. In September 2024, the Senate's Health, Education, Labor and Pensions Committee subpoenaed Dr. De La Torre to testify about what had happened. He refused to show up. The full Senate, a chamber that agrees on almost nothing, voted unanimously to hold him in criminal contempt, a step so rare that political reporters covering the Senate had to go digging for the last time it had happened at all. He resigned from Steward days later, effective October 1, 2024. There was a fourth party in the room by then, beyond Cerberus, MPT, and De La Torre's management team. Apollo Global Management, a separate private equity firm that had become one of Steward's largest creditors and, according to lawmakers overseeing the bankruptcy, effectively held the deciding vote over which of the remaining hospitals would stay open and which would close. Senator Elizabeth Warren wrote directly to Apollo's CEO in August 2024, describing the firm as the fulcrum stakeholder in decisions that would determine whether specific Massachusetts communities kept a hospital at all. The people negotiating the fate of those emergency rooms were, once again, not the people who worked in them. The bankruptcy proceeding didn't end there. In November 2025, a court-appointed trustee filed a 178-page amended lawsuit seeking more than $3.4 billion from Dr. De La Torre and other Steward insiders, alleging that the sale-leaseback deals beginning in 2016 had paid out hundreds of millions in dividends to ownership while leaving the hospital chain itself insolvent. MPT, the landlord, ultimately agreed to waive roughly $7.5 billion in its own claims just to let the remaining hospitals be sold off to new operators and keep the doors open somewhere. The bankruptcy court's own disclosure documents put expected recoveries for ordinary unsecured creditors, vendors, pension claims, the small businesses that supplied the hospitals with everything from linens to lab reagents, somewhere in the low 20% range. Cents on the dollar, for the people who were owed money for services already delivered. Notice what did not happen anywhere in that timeline. Nobody making the financing decisions in 2016 or the exit decisions in 2020 lost their $40 million yacht over it. The people who lost something were the ones who never touched the deal at all. Patients in Ayer, Massachusetts, and in 9 other states, standing in front of a plywood sign, reading 4 words that arrived about 4 years too late to matter. So who actually wins in this business, structurally, regardless of which specific company we're talking about? Not, typically, the operator. The operator is the one negotiating wages with a workforce where personnel costs already eat over half of every revenue dollar. The operator is the one absorbing a median margin near 1%, one bad flu season away from a covenant breach. The operator is the one whose name is on the building when the doors close. Run a hospital well for a decade, and the best outcome is usually survival. Margins stay thin no matter how well it's managed, because the entire reimbursement system, from Medicare to private insurers, is built to push prices down toward cost, not up toward profit. Run it into the ground, and the operator's name is the one in the local newspaper headline. The landlord wins. Whoever holds the real estate under a hospital collects a contracted lease payment whether that hospital is full or empty that quarter, whether it's profitable or hemorrhaging cash, whether the community around it is growing or shrinking. The rent is owed either way, and it's owed first, ahead of nurses' raises, ahead of equipment replacement, ahead of almost every other claim on the hospital's cash except payroll itself. The financial engineer wins. Whoever structures the sale-leaseback and the dividend recapitalization gets their return the moment the transaction closes. Years, sometimes a full decade, before anyone can see whether the underlying hospital actually survives what it was just loaded down with. By the time a system like Steward's shows real strain, the fund that engineered the original deal has often already exited, moved its capital into an entirely different sector, and reported the transaction to its own investors as a completed success. The clock that matters to the fund, 5 to 7 years to a profitable exit, runs on a completely different schedule than the clock that matters to a patient standing in an emergency room at 2 in the morning. And the incumbent wins. In the 35 states with Certificate of Need laws, the hospitals that already exist get a formal seat at the table to argue against anyone who wants to build a competing one nearby. The barrier to entry that was written to protect communities from wasteful overbuilding also, quietly, protects whoever built first, including, ironically, a private equity-owned incumbent defending its own territory against a new entrant. 3 different winners. One thing in common. None of them are on the floor of the hospital when a patient's monitor starts beeping at 3 in the morning, and none of their compensation is directly tied to whether that monitor gets answered in 90 seconds or 9 minutes. Go back to that lawn in Ayer, Massachusetts, one more time. The sign is still there in the photographs, staked into grass in front of a building that no longer treats anyone. Save our hospital. Nobody who painted those letters had ever seen the 2016 real estate deal, or the 2020 exit, or the dividend that bought a $40 million yacht. They just knew the building where their children were born and where their parents were treated had a sign in front of it now instead of a working emergency room. A hospital, financially, is 2 different things stacked on top of each other. A building that generates rent and a service that generates a margin so thin it barely survives contact with a bad year. The 2 don't have to be owned by the same person, and increasingly, they aren't. None of this makes hospitals unique, either. It's the same structure that shows up under hotel brands, under nursing home chains, under strip malls anchored by a grocery store none of the actual landlords have ever shopped in. Hospitals are just the version where the tenant on the wrong side of a bad quarter isn't a retailer losing a lease. It's a town losing its only emergency room. So here's what's left. Once the deal closes and the ambulance still has to go somewhere. Is a hospital, in the end, a place built to heal people, or an asset built to collect rent from whoever's trying to? And if the answer depends entirely on which floor of the transaction you're standing on, which floor do you think you'd actually be standing on? The one holding the lease, or the one holding the sign?